Welcome to the Behind the Drapes podcast. I'm your host, Kenny. In this episode, we talk to Dr. Alex Cohen. Dr. Cohen, in my opinion, is a great example of how, from anesthesiology, you can make your way into hospital administration and work your way up the chain. In this episode, we talk to Dr. Cohen about his training in Boston, taking a quick pit stop in Seattle to do a regional fellowship, and then coming to Rhode Island Hospital where he helped start the regional acute pain subdivision of the anesthesia department, as well as how he got involved in hospital administration. Stay tuned to see what's going on behind the drapes with Dr. Cohen. All right, welcome, Dr. Cohen.
Thank you for having me.
So how's your day today? Your P2?
Yeah, P2 is not a bad day. I got out at 1:30. I stayed for about an hour after that doing some work, but I worked with two good senior residents. So that's always a predictor of a reasonable day, I'll tell you that.
Nice. What kind of stuff were you doing?
For once, I actually did a whole bunch of neurosurgery cases, a couple big neurosurgery cases, a couple fiber optic intubations and things like that. So it was an unusual day for me, but it was a good day.
Makes for a fun morning.
Yeah, and because the residents are so prepared, it was very easy to just, go in, do something different, let them, learn a new skill, which, if things are not prepared, it just starts off on a terrible foot. So let's start off for a good day.
Love it. Love it. Did you do anything else productive in your day after you left work?
Yes, I grocery shopped.
Nice.
Although I think my family ate about half of the groceries that I ever bought. So
are you a Greg's guy? I strike you as a Greg's guy.
I am a Trader Joe's guy.
Oh, nice. Me too, actually.
What is Greg's?
Isn't that East Providence thing or East Greenwich thing? I mean,
isn't that the place that makes the cakes?
Oh, you're right. What's the grocery store I'm thinking of?
You're thinking of Dave's.
Dave's, that's it.
Yeah.
The other generic name.
I'm also a Dave's guy. Yes, you're correct. I'm also a Dave's guy. That's about 30 seconds from my house, so that always makes it easy. But because I got out early, between Providence and East Greenwich, Warwick, hop off the highway and just grab some Trader Joe's stuff because my kids love the snacks and all those kind of things.
Oh yeah, they just opened one in Providence, so we've been there like 3 or 4 times now.
Yeah, it's big, right?
Yeah, it's pretty big. It's right across the street from Felino's downtown.
Okay, yeah, the one in Warwick's kind of smallish, but again, I like to get in and get out and be done with it. So it's same thing every time.
Yeah. And so you lived in Boston for quite a big portion of your life, right? It was undergrad, medical school, and then residency.
Yeah, I left Florida, which is where I grew up, at 18, never to return. So I lived in Boston, as you said. I basically lived in Medford for 2 years for undergrad, and then the second 2 years of undergrad, 4 years of med school, and then all 4 years of residency. I was at Tufts, so I lived in Chinatown for 12 years.
What do you like better, Providence or Boston?
Oh, they're so different. I mean, Boston, I have like this nostalgia for,
right?
But like, it's definitely much more enjoyable living here. Every time my wife's family's from, outside of Boston, and every time we have to drive back through the traffic and things like that, I'm just like, oh, I'm so glad we live in Providence. Even our worst traffic is a tenth of what it is in Boston. So from a lifestyle perspective, it's exponentially better.
Right. Did you have your eyes on this place when you were like finishing up training?
You talking about Providence or
and like Rhode Island, and both.
So as you said, I did Tufts residency. While I was the senior residents at Tufts used to rotate down at the old Providence Anesthesia Group, which was our predecessor. We used to rotate down here for pediatrics and thoracic surgery because we didn't have numbers up there. And so in my second to last year, rotated down here. When I became a chief resident as a CA3, me and my co-chief actually really liked coming down here so much that we started an advanced rotation so that we could come back as well as any of our classmates. And that actually stayed for a couple more years after, we'd graduated and gone to fellowship and whatnot. And so we created advanced rotation to do regional anesthesia and more peds, which people really loved. And it was a good experience because, there was the ASC here, which there really wasn't a which is our ambulatory center. There wasn't really a similar thing at Tufts. So it was awesome. While I was down here, the former chair, which was Dr. Burt, sat me down in the old cafeteria on the window and goes, I'm not going to try his accent because he had this, booming voice, but he sat me down and he said, "So, Doc, your regional anesthesia skills, we're opening up a new orthopedic surgery center. We would love to have those skills when you're done with fellowship." And so I said, "Oh, that sounds pretty good. Put it on the books to have an interview." And I went to fellowship, and while I was home no, let me rephrase that. Before I left for fellowship, I actually interviewed with this group. And then while I was home for Thanksgiving with my wife and my new baby visiting her family, I got a call from Chris Divignan, who's one of our other vice chairs, and said, "Hey, we'd love to make you an offer. We'd love to have you join the group." At the same time, they offered two of my former residency mates jobs, and we all kind of joined the group at the same time. So it kind of flowed nicely, and it was a group that I knew well. I knew a lot of the people. Some of it come down from Tufts, but it was kind of an easy transition that I was pretty confident I was going to be happy with.
Cool. Why anesthesia in the first place?
Why not? No, I'm just kidding. My path to anesthesia was a little funny. I think that anesthesia probably found me more than, the other way around. I started, when I finished medical school, I matched into a categorical general surgery spot. And then throughout the course of that intern year, I kind of realized that I actually didn't like operating. I liked the operating room. I liked, the high acuity. I liked doing procedures, things like that, which, is very common. But I really didn't like operating. I was fortunate that one of the people who was in my intern class actually had quit her categorical anesthesia spot to go follow her significant other, I think it was her fiance at the time, to a spot at Vanderbilt where he had taken a professorship. And so I was able to talk to the program director and kind of convince them that I would be a good fit to join their program. And I was the last year where you could just do a swift little move over from, intern year in specialty X to whatever your categorical spot was. And so I did that, never looked back, and it served me pretty well. So I think I say that was probably like the defining moment of my career, is like that ability to move over, set things in motion to end up where I'm now.
Yeah, it's pretty cool to identify like a single moment like that. Do you
Yeah,
feel
for
like
sure.
your interest in surgery, that background is what guided you towards regional as like a subspecialty within anesthesia, or was there something as you were going through your residency experience that drove you towards it?
Interesting question. I don't think it had to do with surgery so much as liking the procedural aspect of things. So I really like ultrasound. Obviously, everyone likes doing procedures, putting needles, places, things like that. I think that when I picked doing my fellowship, the amount of jobs on the market was so unclear. Now if you are in anesthesia, there's a job for everyone, which is great. I think that's awesome. But back then it was unclear where things would go. Would there be enough docs? Would there be too many docs? Would there be too many CRNAs, not enough CRNAs? Would there be too many residents, not enough residents? And so all those things, I kind of was like, I need something that's going to give me a little bit of, a standout. And I really like the procedural aspect. I think I've probably had this conversation with you. If you love cardiac, do cardiac, or if you love TE, which I didn't. If you love kids, you got to do pediatrics. I didn't like that either. And then other than that, there were no other specialties that really seemed interesting to me. And so I kind of said, well, this works out nicely. It's a good fit for the type of people I like to be with. And it's a good fit for the type of procedure that I like to be involved with. I kind of went through my training being like, if I could do this case with one IV, that's as happy as I'm going to be. So regional anesthesia, orthopedic anesthesia, we're perfect for that.
Cool. How was your time in Seattle? Did you like Seattle?
Seattle was interesting. So the city itself, my wife loved. We live right downtown, right next to, I trained at Virginia Mason. So
Right.
It's on First Hill, and right down in the thick of things. Uh, my wife loved it. We had a new baby. She'd take him to all the lakes and the parks and the things like that. My time mostly consisted of going from our apartment, which was in Capitol Hill, kind of trendy, music, grunge, little drugs and alcohol kind of area, walking maybe a mile, maybe a little less than a mile, every morning, and then back to and from work. And so, Seattle was fine.
Yeah.
I really like the training I got. I really do
Yeah.
like the people that I worked with and things like that. I think that hospital system did, quality. Everyone was always on the same page. The way that they approached patient care, from a system level, every person bought into it. And so it was really easy to take part of that, to be part of that, and to become part of the team, which
Mhm.
I think a lot of hospitals and systems struggle with. So that was really where the benefit was for me, seeing that system, learning from really really good, great people who have a history. Right, when you talk about anesthesia, regional anesthesia was the first, and so a lot of that came from Virginia Mason, and so there's just a lot of good history there.
Where do you see this field going? Like, if like 5 years from now, do you see regional becoming more of like just an ASC thing, or do you see like every generalist being comfortable with, 5 blocks like in their toolbox, and it just becomes like an expectation that everybody knows how to do this? Or do you see them sort of separating themselves and making a distinct subspecialty?
I mean, so the fellowships are now all ACGME accredited, which not all, most are ACGME accredited. Which when I went through training, none of them were. It came about 2 years after I came out. The changes in the job market, I think the changes in the way we train people, the fact that ultrasounds have gotten so much better, and there's been such a significant uptake of regional anesthesia in the past 10 years. It's an expectation that everyone who graduates is able to do, like you said, these basic things. You got to be able to do upper extremity blocks, interscaling, supraclavicular, which you can be able to do essentially every surgical procedure. You got to be able to do some truncal blocks, tap block, PEX blocks, things like that. And then, basic lower extremity popliteal and adductor. Almost everyone we see graduating coming through is comfortable with that. So when you look at our group, the way that we have evolved our acute pain service is that we always have an acute pain attending for the day with, a couple residents, 2, 3, 4, whatever it might be. And then the attendings who have rooms that have blocks in them almost universally do those blocks themselves. And so I think that's a representation of what we see in this field, is that the folks who are coming out of training, because that's most of the people who are hiring, are coming out of training or shorter from training. They're all comfortable. They're all excited. They all want to do those things. Whereas 10 years ago, 15 years ago, that maybe wasn't a thing. You were very unique if you got to do, if you had this skill set. So I think that you're right. It's that second option that more people are going to be expected to have those basic blocks. And then there'll still be a role for regionalists, at academic centers, at places that are doing higher complexity nerve blocks, things of that nature. And then for consultation, it's not the model that we have, but a lot of groups, the acute pain service is a consultation service for med management with complex patients. So there's still a role for it. But to your point of, where do I see this going? I think that it's going to be an expectation. Everyone meets those bare minimums. And I think people want to do that. I think people are, that's an exciting part of their day, an exciting part of their job for most people.
Mm-hmm. I'd agree with that. I love APS. Like, I enjoy the rotation, and I kind of miss it when I'm not on rotation. Like, I wish it was built more into my practice, which is
Yeah.
actually one of the best parts about being at the Merriam, is you're almost guaranteed to be in like a ortho room, and then you get to do spinals and blocks, and those are
Yeah.
fun days.
Yeah. It's funny because we go through, ebbs and flows with the residents, and, some of the senior residents say, oh, the Merriam, it's just, it's all basic. And I'm like, that is what anesthesia is.
Right.
That is
Right. Bread and butter.
99% of anesthesia is blocks, spinals, you know, a little bit more rapid turnover,
LMAs.
relatively healthy people, LMAs.
Yeah.
That's the majority of anesthesia outside of the academic world. And
Right.
obviously, not everyone's going to end up in an academic institution. So more of your practice, assuming you go into OR anesthesia,
Hmm.
is going to mirror the Miriam, maybe a community plus kind of hospital versus a tertiary or quaternary care center.
Hmm. Totally. Since you kind of alluded to it before, when you first were hired at Rhode Island Hospital, did you come in as sort of the head of the department for like our ortho trauma anesthesia / APS?
So when I started, so the contract I signed, or the offer I got, I guess I should say, was from PAI, so the private group. In the 6 months between when I got that offer and actually started, the group went from being PAI, so Providence Anesthesia, to becoming, the Brown University department that we kind of are at now. In that transition, we had a period of time. So when I first started, there were no residents. I don't think they'd even submitted the residency application at that point. So when I came in, basically what I was tasked with by our chair was kind of come up with a plan for what the service would look like. And I can tell you, it's evolved in the 5.5 years I've been here. It's evolved 4 or 5 times because every time we get more residents, we bring out new surgical lines, things like that. The expectations change. The types of blocks and procedures and things like that we do have changed. So it wasn't a perfect one-to-one, like, oh, you will be hired to be the acute pain and trauma kind of orthopedics guy. It was, you're hired as a regional guy. And then, oh, by the way, we have a residency we're starting. And then, oh, by the way, could you get an acute pain service going? So I think it worked out really well. But it wasn't just this linear thing like, oh, you are coming in to have this job.
What's something or a couple things that you think you've accomplished in the past 4 or 5 years since having that role?
Well, so I think that the things that we've accomplished are, it's kind of, every time you think about it, it's more impressive.
Some of your favorites.
Yeah, as a department, I would say we've just grown so much that, for the acute pain service, right? When I started, they were doing 2,500 blocks a year or procedures a year. That's almost 4,000 now. So the volume that we've been able to derive has been awesome. The uptake from our surgeons, the interest, things like that, has just gone through the roof, which is great. I think that outside of just the procedural aspect, which again is awesome, I think we've trained a whole bunch of residents that I frequently get text messages from former grads, some of our people who we've hired that stayed on as faculty, hey, I remember this tip, this trick, whatever, and I was able to have my block succeed with a new junior resident I'm taking through. One of the best ones was that the first residency class we graduated, one of the guys went to a private practice. 2 weeks later, after graduation, he texted me. He had just started. He said, I just did a block that no one else could do. No one else could get a view, couldn't get it together. And I did what you told me. I scanned down to the supraclavicular. I scanned up to the nerve roots at the cervical, at the level of the cords and the roots. And I literally traced the local back. And I was confident in that block when no one else could even find anything. And so I think that was kind of a cool thing to be like, wow, we're actually making people who will go out and do this on their own. You
That's
don't
huge.
realize
That's a cool feeling. It's a really cool feeling.
So I think from a regional standpoint, those have been huge. We've recruited a couple of folks to join the regional group who are actually regionally trained. So we have 2 other folks, and then we've grown the host of, or the complement of kind of faculty that are able to help, want to help, play a big role in the department and the acute pain service day to day. And those are the folks who are maybe generalists, or we have a few regional cardiac, regional PD people that help bring in more volume, help kind of make things a nice stable flow for the day when it's really busy. And I think that seeing them join the fold and help train the residents has been awesome.
Sweet. This is an intermission. You're about halfway through the episode. Now would be a good time to take a break, put the podcast down, and come back to it at a later time. If you're really into the episode and you want to keep pushing forward, then just push ahead 15 seconds and keep on going. If you do take a break, you're going to want to be sure to come back because most of the guests seem to save their best for last, and you're not going to want to miss what's coming up next. Yeah, definitely. I definitely agree that it seems like all the young, new hires that we've had in this department are all very comfortable teaching blocks. And I find myself, like when I was on APS and it was late in the day, you could just grab whoever was in pre-op and say, hey, can you staff this block with me? And there was almost no question that they would be able to do it with you.
Yeah. And I would say that if you look back 3.5 years ago with our first class of residents, that wasn't true at all. I used to stay late multiple days of the week to, do the PEX block at 5:30, to do, the tap block, the paravertebral, erector spinae, something like that, there wasn't anyone around to do. And now I don't even worry about it. I don't even look at the list to see, is there someone? Because I know that of the 6 people, there's going to be one.
Right. Yeah, it's really cool. So do you think that position that you came into sort of led you to taking on administrative roles within the department? Because when you look at sort of the way your career progressed, it seems like you've been able to dip your toe and really now enter the room into the administrative part of the hospital.
Yeah. I mean, I think it definitely did. I think that the success of the acute pain service kind of allowed me to leverage it into other roles, meaning I went from being the director of the acute pain service, which I obviously, developed and established, to becoming a vice chair of our department over the course of about 2.5 years. And I think that transition was an important one because that's what ultimately led me where I am now, where I have a hospital and department level roles. So going from acute pain to the vice chair role, it was really just always about being available. When people had a question about anything related to anesthesia, they didn't want to bother Gil with, hey, does this person, need to be MPO? Can, these basic questions, building connections by being the one that was available. So every nurse has my phone number. Every tech has my phone number. Every PACU nurse has my phone number. When they have a question, they just pick up and call me. And so you start to get involved in things. Hey, we're having an issue with this. Can you help us? Yeah, I'm happy to help. And just having that mentality of yeah, I'm happy to help. How can I help? Being available, getting an answer, following through, even if I don't know it. So if I get a call back then from, the PACU manager, hey, we're having issues with sign out, or we're not getting the I's and O's or whatever it is. I don't know actually how we get that done, but let me look into this and I'll get back to you. And even if I wasn't the person to give them the right answer, I'd be like, hey, go talk to Chris, because Chris is the one that knows the answer to this. So let me put you guys in contact. Here's his phone number. When you did things like that, all of a sudden you became a valuable person to the department because you were, someone who people could look to, someone who people know they could depend on. And so that became our chairman being able to depend on me. And it was like, okay, well, now we need to deal with COVID, right? That was kind of the first big thing for me. Okay, we need to deal with COVID. How do we do that safely? What are the protocols we need? How do we protect the machines? How do we protect our staff? How do we protect other patients? Someone's got to do that and be up to date on it. Okay, you've been available, you've been involved. Why don't you do it? Okay, sounds good. And then that led to, we're going to grow our GI service and our EP service and this. Help do that, take care of that, take care of that. So that created more and more opportunity within the department. And then once you had all those departmental roles kind of set up, and you're like, I'm doing all this stuff. When they were changing the OR structure, Dr. De Oliveira came to me and said, hey, we're going to play a bigger role in running the operating room along with our, nursing and surgical colleagues. Are you interested? And I was like, okay, sounds like a good gig, doing a lot of the things I'm doing now, but actually getting a little more support, a little bit more time to do them. And, having the ability to actually drive change from within the system, as opposed to when you were, the anesthesia vice chair, every change you had to do, it was me. I'd always say it was beg, borrowing, and stealing from someone to be like, hey, can you do this for me? Hey, could you do me a favor? Hey, so you get it's a little bit easier to do it in some ways from where I am now.
Yeah, I think that's really sound advice that you gave at the beginning, where you said make yourself available, and then people will get comfortable asking you. And then from that, you become reliable and dependable. That was a very natural progression that your career seemed to take.
Yeah, and
Um,
I think that probably goes back to my surgical training, which was, everyone, my intern year, when they're telling you, oh, you got to build a practice and this, you always got to be available, to your patients, to other surgeons, So that kind of stuck with me. And I think that that's kind of where it goes back to.
how are you at saying no when somebody asks you to do something?
I've gotten much better at that. And it depends on what it is, right? So I think I've learned that there are some things. So I also take care of our department's anesthesia equipment. So I used to take every meeting from every vendor who was trying to sell something or, was a sponsor of our equipment. Every time the Draeger guy or the stores guy wanted to talk or, hey, can I just show you this new equipment or can I help you with it? I'd say, oh, yeah, come on, come on, come on. And to some degree that helped, right? Because then every time I needed something, hey, we're having a problem with this piece of equipment, I could pick up the phone and call them, right? So it kind of worked both ways. But now as I've moved on, I have a little bit more on my plate day to day. Now I've realized, some of those people, if it's an item or a product that we are never going to use, or maybe we don't, they get put to the no pile. Like, hey, sorry, I appreciate you reaching out. I'll keep you in mind if we ever need you in the future. No, I'm not going to spend an hour of my day with you. Then you have things that, you kind of know you have to do, but they're not right now. So it's, oh yeah, I'm happy to write you that letter of recommendation. Let me know 8 weeks before the deadline. I'll get it together for you. And then you have the things that are like, coming directly from above, like, hey, I need you to do this. And that's like, you drop what you're doing, you take care of those things. And then the last group is the things that you want to do and the things that are going to be valued by, external things, getting a call from a PACU nurse or pre-op nurse. Hey, my family member is having this issue. They're having surgery. Can you help make sure that, they get the anesthesia person I like, or, things like that. Those are things that you want to do that I still make plenty of time for because I think, again, they're valuable. Those relationships are what allow you to succeed. And so I've definitely gotten better at saying no, but it's also about prioritizing it. So I'll say no, but I can do it, at X point when I know I have a little time.
I think you just described the process of triaging, which is what makes any
Yes.
good physician a great physician.
Yes, that is true. I mean, that is functionally what you're doing. It's as the days get busier, as I have a very busy clinical load. I usually cover a full assignment plus our acute pain service. And then I have a lot of, administrative stuff. So I've learned that you can't always do everything yourself. I certainly rely on a lot of my partners for clinical stuff. Ask Dr. Hunter and Dr. Wartzman how many times a day that I call them looking for them to help wake a patient, start a case, things like that. But I used to feel kind of bad about doing it, and I don't anymore because I just realized I would do the same for them, and it's
Right.
a team
Right.
sport more than maybe you realize even.
Right. Absolutely. Can you take us into like an average day of like what the vice chair of logistics does? Like what is your role? Like who are you in the room with? What kind of meeting? Like what's an average day look like?
Uh, okay, average day. So I'll give you like kind of a mediocre day.
Sure.
Um, so the yeah, so for example, on a day like today, I would come in at about 6 to 6:15, and I go to my office, plug in my computer because I bring that home every night to do a little work. Plug in my computer, have my cup of coffee, look through some emails from the evening into the morning. I'll go through any safety events from the OR overnight because we get those, in real time. And then I'll start looking through my cases for the day. Usually, and today wasn't a day, but usually if I'm an acute pain attending, I'll look through the pain list that has been sent to me by the residents the night before. I'll do my own comparison to make sure that they either, didn't miss things or things that they may have thought were appropriate for, a block or a spinal or something like that, that are corrected at that point. I make a flow for that morning. So I'll text message the APS residents and kind of set them to, make sure that they know where they need to be. And then I'll talk to my residents for the morning and, let them know any changes. Because I cover the orthopedics trauma room, there's usually a lot of, moving around in the morning for that group. So by 7 a.m., I've laid all those plans, responded to my emails. If I'm lucky, I'll get a little bit of time to do, some work on some presentations for the upcoming days. 7 o'clock, head up to the operating rooms, see my patients, help put in lines, things like that, do any blocks that need to occur before the 7:30 or 8 o'clock rush, start my cases. And then usually by about 8:30, 8:45, things have stabilized. So that's a moment where I can say, okay, I'm going to go get a cup of coffee. I'm going to check my email again, and then give any breaks I have to. Touch base with the APS residents while I'm giving the breaks, moving around. And then at 10 o'clock every day, we have our schedule meeting for the operating room. So as medical director of the operating room, we have a schedule meeting every day. It involves all the service line leads for the operating rooms, myself, the business director for the operating room, the nursing directors for quality, pre-op PACU, the OR, as well as some other engineering and business folks. We have this meeting to make sure that all the cases are placed appropriately, that anything that people have booked since, the previous day is placed appropriately into location, time, things of that nature. And that sets the flow for the next few days to be, a little bit more seamless. That usually goes to about 10:15, 10:20, if we're unlucky. And then I usually have meetings from about 10:30 till 11:30 or noon. Who those are with depends. I have an admin who is awesome and helps make sure that I, don't overlap too much. And then we start lunch breaks. So we'll give 1, 2, 3 lunch breaks depending on what the day looks like. Obviously, if there are any blocks or procedures in there, starting cases, I run up to the OR to do those things. And then we'll do some teaching in the afternoon. Usually finish my lunches, finish my teaching, get back to my office, maybe 1 o'clock, do the same thing again. Emails, usually I book a couple meetings between 1 and 3 o'clock. Around 3 o'clock, if you're not on call, we start to hand off cases to call providers. So I'll hand off some cases to call providers. And then I usually stay for another 2 hours to actually do some work. So finish responding to emails, presentations, do a lot of data gathering and analytics for the OR, both for quality as well as efficiency. So I'll usually dig through some of that data at that time to make sure that we're not missing any trends, make sure that, everything I need to evaluate for first case on time starts, turnovers, things of that nature, I've at least taken a peek at, and then, responded out through if I need to. Hopefully at that point I go home. And usually there's at least 3 or 4 cups of coffee in that mix that I probably didn't know.
Nice. Yeah. Sounds like a pretty full day.
Yeah. It's usually a busy day, but they usually go by pretty quick. So that part's always nice.
How did it feel? Well, do you remember the first day you had your new office? Like what that feeling was like, getting your own office?
So I had an office before this. It was a little further from the operating room, so I did not use it as much. And I shared it with a few people, which was fine.
Over in
This
the
office
APC?
in the APC, yeah.
Yeah.
So as you know, that's not a reasonable distance to kind of do clinical work at.
Right.
My new office is right below the OR, so it's, I would say 30 seconds away at all times. So the first day I went in that office, it was kind of yuck. It hadn't been cleaned up, things like that. So first thing was cleaned up, painted, new desk. And then about a week into it, I kind of had that feeling you're describing, walking in being like, wow, I have my own office. Like I have a window.
It's
Oh,
pretty
that's
cool.
kind of cool. Yeah, exactly. So that feeling was pretty nice to be able to say like, okay, I have a place where I can actually hold meetings. I have a place I can get work done. And really the amount of data I work through, having like the 2 big screens to be able to do work on, which I don't even have at home, is absolutely awesome. I mean, that's a game changer. So I love that aspect of my office.
Very cool. All right, in the last couple minutes we have left, I'll leave you with this question. For someone who still has such a young career, but kind of found theirself in like a department that was getting new leadership, and you happen to be part of that leadership and now have ascended pretty quickly in that leadership, what gets you out of the bed in the morning to like, what do you strive for? And like, where do you see your career going in the future?
Good question. So I think the thing that gets me out of the bed in the morning is the people I work with. I mean, I really do like the people I work with. I know all the PACU nurses. I know all the pre-op nurses. I know most of the OR nurses, the residents, I know the people that I work with, and I really love that. What gets me motivated to like go to work at 6 o'clock as opposed to 7 o'clock, because 7 o'clock would be the go talk to all these people, is the ability to make small changes, to improve things. When I was just vice chair, that was what motivated me all the time, to be able to make small differences. Most of it was for our people, right? So for the anesthesia folks, it was like, oh, the ventilators aren't working well. Let me see what I can do to get better ones or to get them fixed. We need more ultrasounds. We need more of this. We need that. We need to, adjust this. So back then it was all about us. And now I've got like a bigger group of people to try and help. Now the surgeons will often call me with issues. I'll get calls from nurses that, how I can help to, whether it's a safety issue or quality or whatever it might be. So the ability to like kind of tackle those small tasks day to day, I really love. And you can have small wins. Now I'm at the stage, I've been in this role for, for maybe 6 months, give or take. And I've realized that the small wins are what get you through day to day, but then it's the big wins, the like, trying to really change quality or to change the way we do something as a whole unit and working through that as a team. We have so many meetings looking at these various things, and they're so complex. Whenever you think about it, you're like, oh, that's not that bad. And then you get into the nitty gritty, you go, holy good God, this is just so much more complex than you think. So now I'm at that stage where we're starting to have groups working through a lot of these things, and it's not just the little things anymore. I think there'll be more big things. What was the second half of that question? I can't remember.
Where do you see your career going?
Oh yeah, I don't know. It's been up to this point, I just let it flow, right? Surgery's not working out. Well, let's go to anesthesia. The job market's tight. Go get a good fellowship. Oh, okay. This job, it looks like a great job. You should try it. Okay, great. Let's try it. Oh, you're going to start a division. Okay, great. Oh, now you're going to help build up that. So I'm just going to follow it and see where we go. I love where we live. I love the people. So I'm going to stay where we are, and I'm going to just see where things go naturally.
Awesome. Well, I'm excited to see where your career takes you. Thanks for spending some time with me. I took away some really helpful information and advice on how to be available and be a leader. And it's been awesome talking to you, man. Seriously, that was cool.
Good talking to you too. Thank you for having me. I appreciate it.
All right, buddy. I'll see you later.
Bye. Thanks, Kenny.
Thanks for listening to this episode of Behind the Drapes. If you like what you hear, be sure to hit the subscribe button so that you can get all the new episodes of the show as they drop right to your homepage. If you really, really liked what you hear, be sure to rate and review so that other people can find the show easily, and also tell a friend so they could check it out too. Special thanks to all the guests who come on the show and help make my job a lot easier, and hopefully make an entertaining time for you guys to listen to. We'll see you next time.